Before I begin, I would like to disclose that I have no financial relationships or conflicts of interest to report. This program has received financial support from CIHR and the NSHA Fibromyalgia Research Grant in the form of educational grants, and there are no potential conflicts of interest to disclose. There are no potential source of bias disclosed, so no medication plan is required. Now, I'll get started with my project. Prior research has shown that trauma exposure is elevated in chronic pain and may differ by sex. Developmental and lifetime trauma have both been linked to chronic pain, but they may relate differently to pain outcomes. Interpersonal trauma has also been associated with worse psychological outcomes, and greater cumulative exposure has been linked to higher symptom burden, including worse pain and effect. However, important gaps remain. These trauma dimensions are rarely examined together in the same chronic pain sample, and it remains unclear how they relate to pain, affect, and trauma related outcomes. This study was designed to address these gaps. The study included 149 adults with chronic pain, including fibromyalgia, chronic back pain, or both conditions. Participants were recruited from clinical and community settings in Halifax, ranged in age 18 to 75, and had a mean age about 42. All met the established diagnostic criteria and were medically screened. The study used the cross sectional design. Measures were completed electronically through REDCap using a standardized battery of validated self report questionnaires. Ethics approval was obtained, and all participants provided informed consent. Trauma was assessed across several dimensions. Lifetime trauma was captured using the brief trauma questionnaire, while developmental trauma was assessed using the childhood trauma questionnaire and adverse childhood experience questionnaire. Interpersonal trauma was defined as physical and sexual violence. Trauma timing was classified as childhood only, adulthood only, or combined exposure, and cumulative exposure reflected the number of trauma categories endorsed. Outcomes were grouped into pain, affective, and trauma related domains, analyzed using the listed variables respectively. Analyses included chi-squared test and Mann-Whitney-U test for prevalence and sex differences, and Spearman's correlation for clinical association with false discovery rate correction applied for multiple comparisons. First, trauma exposure was highly prevalent in this sample. Women reported high rates of sexual violence, whereas men reported high rates of combat exposure and marginally high rates of physical assault. However, there was no overall sex difference in total lifetime trauma exposure and no significant sex difference in developmental trauma exposure by type. Overall, the main pattern was there was a difference in trauma type, not in overall trauma burden. Next, I examined trauma timing across the lifespan. Combined childhood and adulthood trauma was the most common pattern, accounting for 64.7% of the participants. The childhood only and adulthood only groups were much smaller, so these findings were interpreted descriptively rather than as a strong group based comparisons. Overall, the pattern suggests that trauma exposure in this sample often span across both childhood and adulthood. Furthermore, I examined interpersonal trauma. About 60% of the participants reported at least one interpersonal traumatic event. The interpersonal and non interpersonal trauma groups were age and sex matched. The violent plots show higher post traumatic stress, depressive, and both trait and state anxiety symptoms in the interpersonal trauma group. Dissociative symptoms were not significantly different. Overall, the interpersonal trauma was linked to greater affective burden and post traumatic stress symptoms. Finally, I examine pain, affective, and trauma related outcomes. Panel A focuses on affective and trauma related outcomes. Lifetime trauma exposure measured by the brief trauma questionnaire showed the broadest pattern of association with higher pain catastrophizing, post traumatic stress symptoms, state and trait anxiety, and dissociative symptoms. Developmental trauma showed more selective pattern. Adverse childhood experience scores were associated with higher post-traumatic stress symptoms and dissociation, while childhood trauma questionnaire scores were associated with higher post-traumatic stress symptoms, with some additional uncorrect association involving anxiety and catastrophizing. In this figure, asterisks indicate association that survive fall discovery rate correction, whereas crosses indicate findings that were significant at the uncorrected level only. Overall, panel A suggests that lifetime trauma was more broadly associated with affective and trauma related burden, while developmental trauma was more specifically linked to trauma related symptoms. Panel B focuses on pain related outcomes. Lifetime trauma exposure showed the clearest pattern of association with clinical pain burden. Higher lifetime trauma scores were associated with greater McGill affective, sensory, and total pain, as well as higher pain severity and interference. Developmental trauma showed more selective pattern. Adverse childhood experience scores were associated with lower pain tolerance, while childhood trauma scores were associated with higher affective pain and lower pain tolerance. After correction, the clearest robust finding was the association between lifetime trauma exposure and pain interference and severity. Overall, trauma exposure was highly prevalent in this chronic pain sample. Sex differences emerged in trauma type rather than overall prevalence. Combined childhood and adulthood trauma was the most common pattern, and interpersonal trauma was linked to greater affective and post traumatic stress symptoms. Finally, lifetime trauma was more strongly associated with pain severity and interference, whereas developmental trauma was most closely related to lower pain tolerance and trauma related symptoms. Together, these findings support a multidimensional trauma informed approach to chronic pain. There are few limitations to acknowledge. The study was cross sectional, so the findings show associations rather than causation. Trauma was assessed using self report measures, which may introduce recall bias. The trauma timing tools were uneven, and the sample was predominantly female and clinic based, which may limit the generalizability. Even so, the findings suggest clear next steps. Use longitudinal designs, recruits more balanced trauma timing groups, capture a broad range of trauma severity, and continue to strengthen trauma informed assessment in chronic pain care. I would like to sincerely acknowledge the people who supported this project. First, thank you to my supervisor, Dr. Javeri Hashmi, for her guidance throughout this work. I also want to give special thanks to Cameron Calder for helping me throughout the project at every step. And I'm also very grateful for Janika, Aliraza, and Yatin Narushi for the support and encouragement along the way. Thank you.